Hello, everyone. Thank you for joining. My name is Gloria Brand, and I'm the director for the Brigham Program in Opioid and Pain Innovation at BWH, and I'll also be the moderator for today's Opioid Innovation and Recovery Symposium. And just for the record, the Opioid and Pain Innovation Program is also the acronym for that is POPPY. So if you hear me referring to POPPY throughout the rest of my intro, that will be why. And we welcome all of you today. Thank you so much for joining us. We're just excited to be one of the representations at the Brigham to honor National Recovery Month as deemed by SAMHSA. Today, Poppy, along with the Brigham Health Clinic, Bridge Clinic, rather, have come together. We are collaborating on this event to honor those whose lives have been lost due to opiate use, along with those who are still in the fight and those who are dedicating their lives to help in this epidemic, which you'll be hearing from some of those folks today. Over the past decade, the opiate epidemic has claimed hundreds of lives in our country, over more than 2,000 lives in the Massachusetts area alone within the last year. So unfortunately, the opiate crisis knows no bounds with who it affects, and the way in which opiate disorder enters the lives of each person is very, very unique. So today, we want to really hear about some of the Brigham's innovators, researchers, and scientists and friends who are working to serve the OUD population as well as treat those disorders in very unique ways. Who we have on our panel today is Dr. Gershonik Esteban Gershonik, who is a medical doctor here at the Brigham. We also have Dr. Lena Mattal. She'll give a little bit more information about herself, but she's also a director in the Women's Health Department. We have Carla Matero, who's an MSW and a recently new licensed clinical social worker, who's also from the Brigham Health Clinic. And then we have Mimi Yen Lee and Joyce Zhou, who are fourth year Harvard medical students who will be talking to us. And last but not least, we have Dr. Escobar, who works within CSPH, the Center for Surgery and Public Health, doing a trauma program / project called Forte, and he'll be talking to us a little bit more. So without further ado, we want to go ahead and start our symposium here today. Again, we're going to start off with Dr. Lena Mattal from the Women's Health Clinic. Thank you, Dr. Mattal, for joining us. And please, by all means, give us a little introduction of yourself and feel free to jump right into your presentation.
Thank you so much, Gloria. Thank you for having myself and Carla from the Bridge Clinic. I'm really pleased to be able to share a little bit about what we're doing here. Just by way of a bit of introduction, I'm a perinatal psychiatrist, so I specialize in psychiatric care in women who are pregnant, postpartum, in early parenting, or seeking to become pregnant. And within that, I have had the privilege of really taking on and becoming more and more engaged around the treatment of women with substance use disorders that are also in the perinatal period of their lives. And so that's sort of the reason how I came to be involved with the Bridge Clinic. And I am going to also just share a little bit with you that I'm the associate medical director for a program called McPap for Moms, which is a statewide consultation program helping providers across the state to address pregnancy, postpartum, and perinatal mental health needs along with substance use disorders. And so some of what I'll be mentioning today will have a little bit of reference to McPap for Moms as well. I'm just going to pull up my slides and share my screen. Okay. All right, is it coming through?
Yes.
Okay,
perfect.
Fantastic. So just by way of a little bit of a kind of orientation to who we are at the Bridge Clinic, the Bridge Clinic was founded about 2 years ago now, a little over 2 years ago, and was really founded in the context of really trying to establish or enact this kind of approach that within substance use treatment we call no wrong door. So if there's a patient who is at any stage of recovery with any kind of request around substance use disorders, our goal is to really be able to provide low barrier, rapid access to immediate assessment and management and treatment, including medications for addiction treatment. And so we take a harm reduction approach at the Bridge Clinic. It's been a real privilege to be able to practice in a way where we can really meet patients where they are, and we're able to accept walk-ins during COVID times. So that's been a little bit more challenging. We've still maintained our really low threshold for engagement and sort of low barrier access, but we're increasingly opening back up to be able to accept some walk-ins. And really the way patients come to us is pretty much any which way, but sort of to be clear, in patients with substance use related illness that our psychiatric consultation or addiction consultation services may interface with, the emergency room is another really important point of entry for people seeking either emergency care or just looking for any help at all. They can come to us immediately within that day, be walked over by providers or referred for an appointment with our Bridge Clinic. We are able to provide pharmacologic therapy, so medication treatments. We have some individual support services and group support services, in particular through our peer recovery coach programs, where we are able to engage patients with members of our team who have lived experience and can be supportive. We are really lucky to be able to have providers within our service who have subspecialties. So for example, myself, I have an expertise around the treatment of substance use and mental health conditions in pregnancy. And so we are able to pair patients when logistics allow with subspecialty providers. We have infectious disease, we have internal medicine and cardiology. So we have connections with specialty services. And then also we have, as Carla will tell you a little bit more about her work within our Bridge Clinic, sort of enhanced assessment and assistance around social services and connections to care. And then ultimately the goal is that the Bridge Clinic truly is a bridge, that we're bridging patients to what they'll ultimately do best in. So we're a short-term treatment center where we can bridge people either back to their primary care providers who can provide ongoing wraparound or ongoing integrated SUDS care, or we can connect them to longer term specialty care in the community or within our system as well. So we have a variety of ways that we ultimately can kind of transition patients, and we do this along the way at various points in their care. We have a number of members of our team. We have addiction psychiatry, addiction medicine providers who do prescriptions and can monitor comorbid medical and mental health complications. It's really important to be thoughtful about the fact that our patients don't come with just one problem, and so or one condition rather. And so we are able to really be thoughtful about kind of the interface between a variety of conditions. We have recovery coaches, which again is a real important asset to our work, because ultimately having peer support can be so incredibly effective and sometimes is the key to engaging patients in treatment. And then we have social work and resource specialists. And again, this is really ultimately the linchpin in providing care and ushering people towards recovery. And as Carla will tell you, social determinants of health and meeting people's most important basic needs kind of lays the groundwork to be able to engage them in other care. But just to clarify more specifically, we provide a variety of psychopharmacologic treatment for mental health conditions, but also medications for the treatment of addiction. So Suboxone or buprenorphine is an important component of that. We're able to provide office-based buprenorphine treatment, both in the sublingual form, and we also are now doing depot sub-Q injections in the form of for buprenorphine. And then we also are able to provide Vivitrol and oral naltrexone, which are really important and sometimes challenging to access in the community. And so it's a real privilege to be able to provide those relatively rapidly. It can be historically had been complicated to coordinate this kind of care, and so we are able to sort of, even with, in some cases, a same day prescription. And sorry, the picture just popped up. For those, Sublocade is a newer option that we're providing, and it's been part of what we're able to offer and has really expanded options for many of our patients for whom sort of the usual daily dosing of medication can be challenging. So I want to take a moment to transition a little bit to talk about some of the patients that we see in the Bridge Clinic and that we see sort of generally within the treatment of opioid use disorder. And that's women who are pregnant or postpartum or in the perinatal period, because they have really distinct needs in the context of seeking care. And we all as providers we're presented with these sort of opportunities and challenges when women are coming to us at this time. Now, one of the things we know about substance use disorder in particular, in general, and opioid use disorder in particular, is that women who continue to be affected by using substances during pregnancy sort of are in a subset of women that have a more refractory, more difficult to treat condition. Often women with substance use disorders have faced so much stigma and shame, and they are so fearful of how they may be received when they enter into care that it can delay the time to which they enter care. Often people are really concerned about what are the implications for ongoing parenting, for legal issues, for retaining custody of their children, of the child who is to be born. So legal issues become a huge component of the fear and the sort of barrier to entering care. And we as providers are challenged to think about and measure our own emotional reactions and responses to these patients, and patients are very aware of that. They're also carrying so much of the history that they've faced as they've sought care throughout healthcare, even prior to the pregnancy. And then sort of to layer on top of that, even within the substance use treatment community and mental health community, there's immense challenge in accessing subspecialty care for women who are pregnant. Pregnancy adds another layer of concern about, am I expert enough as a provider to know all of the data and to know all of the best practices? And so that can further limit access. And certainly there are reasons for this. Substance use during pregnancy does present complex set of risks to the woman, to her fetus, to her growing family. Substances that can be used or can potentially be teratogenic, meaning they can cause birth defects. Having a substance use disorder increases the likelihood of exposure to additional trauma, and often is really comorbid with prior adverse childhood experiences and life experiences. Substance use can complicate labor management, most catastrophically, which I'll talk a little bit about. Overdose is a leading cause of maternal mortality in our country. And so the sort of major risk that we are often thinking about is how do we decrease that risk around overdose. Women who are affected by substance use disorder are often engaged less well in their prenatal care for the reasons I described. It's a little hard. They come later to care. They attend fewer appointments around so much of the challenges that they face. They're often faced with other complexities, psychosocial complexities, including limited nutrition. There are placental issues that can complicate growth and development of the fetus, and then withdrawal issues can complicate management of labor, and vice versa. Pregnancy can implicate and precipitate issues around withdrawal. And then most definitely we have to consider infectious risk, especially if somebody is using intravenously, and then also the vertical transmission to the fetus. And so there's so much risk associated with and perceived risk during the course of care for women with substance use disorders during the perinatal period. And so this is one of the reasons why it's challenging to engage in care. But most importantly, substance use is a preventable cause of morbidity and mortality for both the maternal population and for the infant population. And I say preventable is important because I think that while this all feels very burdensome and potentially weighty and challenging, there's also a significant amount of opportunity to impact care. In our state, these are data from the Department of Public Health looking at overdose risk. The risk for overdose for women who are previously diagnosed with opioid use disorder it's really important to recognize that prior to pregnancy, women have a standard risk for overdose, and pregnancy itself actually decreases the risk. Women are more engaged in treatment. There's an immense amount of motivation and optimism that goes with becoming pregnant and sort of the goal, an opportunity to improve their health status. But as the postpartum period emerges, the risk continues to increase back to pre-pregnancy rates and then above pre-pregnancy rates for death by overdose. And one of the things that I think is most important for all of us is to think about the fact that pharmacotherapy with for the treatment of opioid use disorder, that's medications like methadone and buprenorphine we provide at the Bridge Clinic, for example, can significantly decrease that risk. And so here I think is an important, one of the reasons why I think it's so important to do the work that we're doing at the Bridge Clinic is really because we have the opportunity to really impact risk and save lives. And the other piece of the data that I showed is that the rates of use decrease significantly during pregnancy. And this is seen across a variety of different studies and different data sets. But really, the point being that women who become pregnant are much more likely to decrease or totally abstain from use of all substances. This is seen across a variety of substances that can be used at different rates. So for example, alcohol use decreases, cigarette use decreases a little bit less, but still persists during pregnancy. And so what this tells me is that this is a time of opportunity. There's an inherent motivation, there's an inherent opportunity to really impact somebody's substance use disorder. And so women who come to us in the Bridge Clinic really, we really try to lean into as much of what we can, and we can try to really provide them subspecialty care that is mindful of what they're going through in the context of their pregnancy care, but also very much mindful of the challenges of engaging in recovery work during such a complicated time. The data show this, and our practices underscore this, that it's important that women with substance use disorders have gender-focused care that's trauma-informed and responsive. It's comprehensive, so we work really closely with the obstetricians in our system to engage in care that includes planning for their delivery, planning for the neonatal opioid withdrawal that their baby may be at risk for, planning for the complexity of having potentially DCF in their lives. So it's really comprehensive. And then it's integrated with primary care, ultimately ushering people from their pregnancy-related care towards primary care and trying to enhance engagement in care. And then the other component that's always important to be thoughtful about when women are seeking care and are in their childbearing years is that child care inherently is key. And so we are really, we do our best to be as flexible as we can. Women bring it's one of the kind of perks of the job is we get women bring their babies sometimes, and we get to be part of that and help assist in our recovery coaches who have parenting experience are able to really engage around the challenges and joys of that child care period. So it's really important to be thoughtful about all of the comprehensive and distinct needs that women who are in this period are facing. And we're really here to help at the Bridge Clinic, and Carla is such an important part of that, and she can tell you a bit about some of the challenges that our patients face and how we work to really think about comprehensive and broad-based care. We put in a little bit of information about how to access care through us and who are parts of our team. And so while, if you want to take notes of that while we're talking, please do, because I think it's so important for us to be available to all of you. So Carla.
Thank you, Dr. Mattel. As Dr. Mattel previously mentioned, many of our patients have underlying mental illnesses in addition to substance use disorders. And many of them are also experiencing homelessness, lack of transportation, and access to meals. And so in my current role as a care transition specialist, I screen patients for social determinants of health and connect them to community resources, which include access to long-term therapy, primary care physicians, transportation, food, housing, and education and job training. I also assist them in office with applying for food stamps and also applying for SafeLink cell phones, which are free government cell phones, so that it can allow us to communicate with them a little bit better. When the pandemic initially began, we reduced our clinic hours and rotated the staff members to decrease infection, but quickly transitioned into virtual visits. And so we were able to identify many of our patients who were at higher risk for relapse and who would need more support during that time. And so we were prepared to provide that added support. And since then, we have continued to provide in-person visits for patients who receive injectable medications like Sublocade and Vivitrol. And now we're open a few days a week to support patients who would benefit from in-person visits. Some of the challenges are that community resources have limited operation hours and limited staffing. And some of the barriers to care that we had seen prior to COVID was that many patients could not afford public transportation, and they also didn't have access to other forms of transportation. Therefore, a lot of our patients were missing appointments at a higher rate. The other issue is that most insurance companies did not compensate for telehealth visits and or at the same rate as in-person visits, or they didn't cover it at all. And in addition to that, doctors could not provide medications if patients were not seen in person. A lot of that has changed post-COVID, so insurance companies are much more flexible now, and medications can be prescribed after virtual visits. Telehealth has been widely used since COVID-19 and has been deemed effective and sustainable solution for treatment during the pandemic. And so as a result, we have noticed that the show rate has increased by using virtual visits in our clinic. And while we're still looking at the trends, this definitely means that we are able to keep patients in treatment longer because of the virtual visits that are available. And then we did have some challenges with detoxes in the beginning because the access to detoxes were, a lot of detoxes were closed and then also required some COVID clearances. So patients had to go to the ED or a testing center to be tested for COVID and provide a letter stating that they were negative for results, and then providing that to the detox facilities so that they could be admitted. And some of the other challenges were that many patients relied on in-person AA meetings and recovery groups for support. And so a lot of those have been canceled and a lot have been transitioned online. And again, it's kind of difficult at times because a lot of our patients may not have the hardware that allows them to access the internet. So that could be a barrier to care. And this disease is very isolating, so it can exacerbate when the proper supports aren't in place during a pandemic. And so it just doesn't make things easier for them. And some of the issues that we've noticed that has been highlighted, in our community, in the communities of color, is that the pandemic has highlighted longstanding health and social inequities that put minority groups at higher risk of getting and dying from COVID-19. And many minority groups live in, crowded conditions. And so it makes it a little bit more challenging for them to follow prevention strategies. And healthcare access has also been limited for some due to language barriers, lack of transportation, childcare, the ability to take time off work. And there are some historical and current discrimination in healthcare systems that have always also made it challenging for people to access care. And I am going to turn it over to Gloria.
Thank you so much, Carla. I appreciate that. And thank you, Dr. Mattal. Those were great presentations. Carla, I did want to kind of go back with you. That was a great transition from Dr. Mattal to you, but I just wanted to hear a little bit more about your role at the Bridge Clinic and how that's changed since you've been with the Brigham.
Sorry, I didn't realize I was on mute. So my role has been, I have been in a CTS role, and so I will be transitioning into social work. So I will be providing short-term therapy. As Dr. Mattal mentioned earlier, we are a short-term clinic, so we provide short-term care to patients, and we see them for about 3 to 6 months, and then we transition them over to longer care. We do have a cohort of patients who have remained with us since the beginning, and so who are having a little bit more trouble with transitioning, some because of transportation or their lives are so chaotic and they have a hard time transitioning into different areas.
Okay, thank you. And then how about, I know you had mentioned already that there were transportation issues prior to COVID. and you kind of touched on it a little bit just now, but could you tell me a little bit more about issues that were already existing in the community that you feel like may have been exacerbated by COVID or made worse by COVID?
Yeah, so I mentioned that it was the pandemic has highlighted some health and social inequities that have that are risks for the African American community and other minority groups.
Mm-hmm. Yeah, thank you. And then how about your volunteer activity? How has that changed since all of this has come about?
So many people in my community don't have access to resources. And so in addition to my role in the Bridge Clinic, I'm also the founder and president of the Cape Verdean Social Workers Association. And so I've teamed up with Mass General Brigham and Southern Jamaica Plain and has distributed thousands of PPE to community members in Mattapan and in Dorchester, where I grew up. I've also teamed up with local officials and other organizations to deliver food and produce to the elderly and families in the community as well.
Well, that's great. Thank you so much. That sounds amazing. You guys are obviously doing wonderful work. And we wanted to give a few minutes for any of our folks online. It looks like we have about 96 attendees today, which is awesome. Thank you guys again for joining us. Feel free to put a question in the chat box. We have about 3 to 5 minutes for that, and then I'll go ahead and take those questions and ask those to the panelists. Okay, great. We have a question coming in from Brendan McKenna, and it's saying, do you think the increased OD risk after delivery is related to the period of abstinence while pregnant? And I'm assuming this is to Dr. Matau.
Thank you. Well, thank you for the question. It's a really, really important question, actually, because I think when we're thinking about how do we address risk, we want to think about what's contributing to the risk. I think there are a few things that happen during the course of pregnancy. And I think, and frankly, it's a really important point that during all substance use care, when there are periods of abstinence and then a lapse or relapse, the risk of using what may have been previously used in terms of amount can present a significant risk for overdose and death. There is also an immense amount happening in the early postpartum period after delivery. So it's in a time of incredible increased risk for other mental health conditions. So depression in particular is the most common mental health condition in the postpartum period amongst all women, irrespective of other comorbidity. So depression can potentiate the risk for overdose, whether it's intentional or unintentional. It could be potentiating a risk for relapse to substance use. There's also an immense amount of psychosocial challenge that can be increasing risk to potentially exacerbate risk for lapse or relapse, including the stress of having a baby that may be impacted by neonatal opioid withdrawal and requiring some subspecialty care, having a 51A filed in the context of a substance-exposed newborn, even when the exposure is related to treatment. Having DCF in one's life can be incredibly scary and stressful, and sometimes can result in loss of custody, which is an enormous loss and stressor and point of grief and challenge for any person. And so all of these things can potentiate risk. And then also in the early postpartum period, we're seeing less and less of this as treatment programs are becoming aware of the risk. But there was a practice that while pregnant, women were given priority entry into treatment, and then that slowly gets pulled away over time. They take less and less priority. And so some women were being discharged from treatment, and that can also remove a fair amount of support and risk, support that will exacerbate risk. So I think all of these are contributors to that increased risk.
Thank you. Thank you so much, Dr. Matau. We have another question that came through, and I believe either one of you could probably answer this one. In terms of the Bridge Clinic, what languages can you manage without the need of interpreter right now with your current infrastructure?
With the current infrastructure, I am a native Cape Verdean Creole speaker, and so I can assist patients who speak Cape Verdean Creole. And we also have our recovery coach, Pablo, who is a native Spanish-speaking person. And so he is very active, which is very helpful because a large population of our patients are Hispanic. And so that really helps with the personal touch and the cultural, differences and things like that. So it makes it just gives it a more personal feel for patients when they're in the clinic and being seen.
Great. And Dr. Mattel, do you find that there are any issues or challenges on your end when it comes to serving patients of different backgrounds or languages?
I think that as best we can, we at the Bridge Clinic are really sort of focused on kind of meeting people where they are. And I think often the biggest challenge is just trying to engage people, especially when they're facing so many traumas, and mistrust can be bred by the challenges of just seeking care. So I think that's the biggest thing that we do, and I think we do really well, is have a very open-ended sort of no wrong door approach where anyone can come in whatever stage. I think one of the things we also, I think, do really well is that we try to help facilitate care outside of the Bridge Clinic too. And so I think our staff are really, really skilled at being able to help create bridges and create facilitation where they can. So even if that means helping somebody pick up a prescription because because we need to help them with the administrative component of it, or navigating the system, our staff are just so willing to kind of roll up their sleeves. So I'd say it's something that I feel really proud of, and being part of the Bridge Clinic.
Thank you. Very good. Very good. Okay, we have a couple more questions coming in. We're going to try to get these in time. This person says, Michelle, she says, I'm a home care nurse, and I wonder, what is the screening tool you use, and do you have any thoughts on the CBRIT tool?
Sorry, could you repeat that question? I think what tool?
Sure. No problem. It's this SBIRT tool. So are you familiar with that tool?
With Esper, yes. Thank you for clarifying. So one of the things that we do within the Bridge Clinic, but especially in Make PAP for Moms, which is a sort of statewide organization, is we collaborate with with quality improvement networks that are really impacting the way substance use screening is taking place in a variety of settings, in particular prenatal care settings. And so our OB practices are rolling out this approach called Esper, which stands for Screening, Brief Intervention, and Referral to Treatment. And so they're gradually and slowly taking on increased screening practices for substance use, and then also training up in how to engage women in a conversation about it, affect a little bit of change, and address how they can increasingly engage women into care, and then referring on to subspecialty care. So that's what the Esper model is, and we're seeing that increasingly roll out within prenatal care.
Great. And I think we have time for another question. This is a good one. Can you talk about, Dr. Mattel, Vivitrol's use during pregnancy, if a woman would prefer this? Like, what are the implications of that?
So the evidence base for medication treatment for opioid use disorder in pregnancy lies with methadone and buprenorphine as first line. Those are our usual approaches, and buprenorphine either in the form of Suboxone, which is the combination formulation, or Subutex, which is the brand name for the single formulation. Methadone is provided through federally licensed or freestanding separate programs. We are not currently able to provide methadone directly, but we do provide Suboxone. Now, Trexone, which is the active ingredient in Vivitrol, is sort of emerging as an option for care that is the data for use in pregnancy are not as robust as they are for buprenorphine and methadone. But one of the things that's most important is really looking at sort of individual level evidence. And so if somebody has not done well on a treatment like buprenorphine or methadone in the past, or they're already on naltrexone at the time that they become pregnant, it may make sense to go ahead with naltrexone. The data we do have is actually quite reassuring in terms of not having additional risk added during the course of pregnancy and still having adequate obstetric outcomes. But they're really just small studies at this point.
Great, thank you. And it looks like we might have time for one more question. What do you think is a best practice for coordinating the many services that this population needs? And either one of you can answer this.
Well, my short answer is to have more people like Carla who to help really meet people where they are and coordinate care with the savvy and expertise that she has. But I don't know what Carla would say.
Definitely.
Well, I would say having a wonderful team like you guys. I think it's been really helpful to have all of the different specialties in our clinic. I think that's been really helpful. If somebody comes in to treat SUDS, and a lot of them haven't seen a primary care physician in years, and so we have two primary care providers in our clinic, which we often bridge to them over at 800 South Huntington, and so that makes it very helpful because a lot of patients, they once they build a rapport with the current providers, some of them don't want to transition. They love the Bridge Clinic, and so they don't want to leave, and so it makes it easier to just bridge them to the provider that they're already seeing. And also, some patients, like I said, haven't seen a provider in years. And so having Dr. Solomon, who's from infectious disease, present, that's really helpful because then we can screen them. All of the providers are screening all of the patients for other infectious diseases. And so it's easier for us to kind of get them into care, because we already are engaging them. So it makes it easier to provide those services.
Well, thank you guys again. That's all the time we have for questions. But again, you see the presentation up now. For more information about the Bridge Clinic and the services they offer, you can email BWH Bridge Clinic at partners.org. If you want more information about the presenters today, feel free to email me, gbrand, at bwh@harvard.org. I'll be sending out more information. This actual presentation and this entire program today is being recorded, so you'll be getting an email from me following up with that as well. So feel free to ask me any questions about any of these presentations today as a follow-up. Thank you guys so much for your time. We really appreciate it. In the essence of time, we're going to try to segue our way on to the next presenter. Our next presenter is going to be Dr. Juan Herrera Escobar. He's an MD and an MPH. He works within the Department of Center for Surgery and Public Health, and he's working on a program called Forte, which he's going to tell us more about. He's going to tell us a little more about himself. And the title of his presentation today is called Pain and Long-Term Outcomes After Traumatic Injury. Welcome, Dr. Escobar.
Thank you. Can you see my screen now?
Yes, we can.
Perfect. Okay. So first of all, I would like to thank you, Gloria and Dr. Weiner, for the opportunity to present on our work today in this symposium. And so I'll be talking about pain and long-term outcomes after traumatic injury. So traumatic injuries is a big public health problem in the United States. In fact, it's the leading cause of death of young adults in the country and in many other countries in the world. And it affects more than 3 million people every year in the US. However, as trauma systems have strengthening through innovation, research, and technology, we've been able to curb the mortality of traumatic injuries and cut it down up to almost that nowadays is about 3 to 4%. So that's great, but that comes also with an extra challenge, which is, what are we gonna do with the 96% of patients that are now surviving traumatic injuries, and that we need to guarantee that these patients go back to their normal lives. So one of the main limitations to understand what's going on with trauma patients in the long term is that we don't have data. And there's something that is called trauma registries that are like the big repositories of trauma data across the country. And one of the limitations of trauma registries is that they only collect data up until the patient is discharged. And in the base case scenario, only until 30 days after discharge. So that's a big limitation to really understand what's the long-term impact of traumatic injuries in this huge amount of people. And the National Academies of Science highlight this gap in their 2016 report, and they called for routine collection of long-term outcomes in trauma. So as part of that call from the National Academies, and to be honest, this call had been for many decades, I think, and we decided to give it a shot at the Center for Surgery and Public Health and start the Functional Outcomes and Recovery After Trauma Emergencies project, with the goal to really try it out and see, is it possible, is it feasible to create a mechanism to routinely collect long-term outcomes after trauma that we can incorporate into trauma registries and understand in a better way what's going on with these patients in the long term. And that was all about it. We started with that purpose, and this initially started at the Brigham, but we expanded very shortly to the Massachusetts General Hospital and Boston Medical Center. And now it's a multi-institutional effort to routinely collect this data since 2015. And we are looking forward to even expand to more sites at the national level. So really, the mission of the Forte project is to transform the collection, the analysis, and the interpretation of long-term outcomes in trauma. And we want to do this through research that may help us create new knowledge, develop new tools to assess quality of life or other domains constructs of the patient's recovery, to highlight and demonstrate the value of long-term patient-centered data in trauma, and really ultimately to transform practice and see how we can really improve trauma care in a way that is reflected in the long-term outcomes of this population. So very briefly, on how does the project work? So we use institutional trauma registries from each of the sites to identify the patients that have sustained traumatic injuries, and 6 months from the time that we are starting the recruitment. So we identify all survivors, adult survivors that have moderate to severe injury, and that's defined through something that's called the injury severity score. And they're either English or Spanish-speaking patients. And so we identify these patients through the trauma registries, then we call them 6 months after their injury, and we ask them a set of different questions about their recovery experience. And these questions are part of multiple domains. Mental health is one of them. So we do PTSD screening, anxiety, depression. We also do a screening for resilience, and we have a trauma-specific quality of life tool and a general health-related quality of life tool also to assess for those outcomes on social health and, of course, physical outcomes, and are also assessed. One of them, for example, on return to work, very, very important for the patients. And so we collect all this data at 6 months, and then we follow up on 6 months later, so a year after the injury, again with these patients. And we combine this information that we collect in the long term in the interviews with the information that we have from the trauma registry, which give us information about the demographics of this population, the clinical characteristics, and the injury characteristics. So everything that is related to their hospital stay and the patterns of the injury, whether it was an intentional injury, it was a car accident, it was a fall, and whether or not they were admitted to the ICU, etc. All those measures are captured there, and then we combine that information to really, and that allows us to really make very interesting analysis of what's going on in this population. So I'll now start jumping in some of the main results of this project that pertains to pain and opioids and substance use. So I'll like to start with this project that we did very early after the inception of the project, and what this study showed was very early on highlighting that chronic pain is one of the most important poor outcomes that these patients are facing after moderate to severe trauma. In fact, half of the patients report having pain on a daily basis on 6 to 12 months on post-injury. And 1 out of 4 of these patients reported to have been taking pain medications daily. So it's really one of the key outcomes that we have identified as being important in this patient population. But what was also very interesting was that the fact that these patients were having chronic pain in the long term was associated with other poor long-term outcomes after trauma that were actually from many different domains, from social health, physical health, and of course, mental health. So patients who report to have pain on a daily basis were more likely to screen positive for PTSD, have functional limitations, and have not returned to work. So I think one of the main findings that we have found with the 4th project as of now is actually this one, and is that all the long-term outcomes are related to each other. Like it's very common to see that when a patient is facing an adverse outcome in, let's say, a mental health outcome, it's usually that doesn't come alone, but it comes with all the other poor outcomes, and this is across domains. So I think that's very interesting and make us think about that the approach that we need to take needs to be very comprehensive and need to involve very different actors and strategies to really improve the outcomes of these patients. So further on, we conducted a study to say, okay, well, this is a big problem, and so we want to understand what are the patients at the highest risk of having pain and be taking pain medications on a daily basis. So we conducted this study with a larger sample size, about 1,000, and we corroborated the findings of the early study that half of the patients had chronic pain and a quarter of them were taking pain medications on daily. But then we say, okay, well, let's take these 2 outcomes and then let's investigate what are the risk factors for each of them independently. And we found that there were some factors that were in common to both of them, to having pain on a daily basis and to take pain medications daily. And these factors were alcohol use, drug use, having a low educational level, and having a longer hospital stay. So those factors were similar to both pain and the use of pain medications. And interestingly, we found some factors that were exclusive to each of them. So for example, for the presence of pain, we found that a younger age, having an orthopedic surgery and an extremity injury were important predictors of chronic pain. And then to take pain medications, we found that some of the predictors were smoking status, number of comorbidities, unemployment, and injury after a fall, and then chest injury. So with this, we were able to come out to some interesting conclusions and really kind of identify that the risk factors are similar, some of them, but there are some differences in the two things, and how we target and how we improve this maybe in a different way. And this really comes up to vulnerable populations. Identifying vulnerable populations is key for intervening and improving these outcomes. And speaking about vulnerable populations, this is a very recent project that actually was just presented a couple of days ago at the American Association for the Surgery of Trauma. And this was really focused on patients who screened positive have a positive toxicology screen for an illicit drug when they showed up at the ED for the traumatic injury. So we found that that the patients that had a positive toxicology screen, which in fact were quite a bit of them, we found 30% of the patients actually have screen positive for an illicit drug, and then this was associated with higher rates of depression, anxiety, PTSD, chronic pain, and social dysfunction. And the strength of this relationship was remarkable, as you can see, with some of the odds ratio. There's a 9-fold increase of having a mental health disease when a patient, have a positive toxicology screen, which really makes us think about, maybe this is an opportunity for identification of patients. Like the trauma admission can be an opportunity for screening patients, for making a toxicology screen and identify patients at a higher risk of having poor long-term outcomes in the future, and then make interventions. So in terms of what are we heading towards in the Forte project, we recently extracted many different variables regarding the opioids on prescription of the patients when they were at the trauma admission. We extracted all that data from the medical records, and we are merging all that information with the trauma registry information and the Forte interviews, so that we can really understand how the prescription patterns of opioids at discharge may or may not affect long-term outcomes in this patients. And in the right side of the slide, you can see some of the variables that we extracted, so we may be able to see whether or not there is an association between any of this prescription patterns and the long-term outcomes of the patients. In fact, we found that close to 75% of the patients were prescribed opioids after injury. So that's related to the Forte project. But also quickly before I finish, I wanna briefly tell you something about this project, which is the NTRAP project, on which the Brigham is being a key actor. So this is the National Trauma Research Action Plan, which is a project that is a nationwide project that is funded by the Department of Defense, and is really trying to put together a research agenda for trauma. So it's really putting together all the experts in the country to say, okay, what are the areas and the research questions that we as a community should focus in answering and addressing in the next years. And one of the aims of this initiative is completely dedicated to long-term outcomes in trauma. And we at the Brigham and at the Center for Surgery and Public Health are being able to be part of that work, and which is define what are the optimal metrics to assess long-term functional outcomes in injured patients following discharge. And I just want to show you on what we have found for pain as of now. So as part of this, we're following the Delphi methodology to come up through a consensus on what are the outcomes that we should be using to measure long-term recovery after injury. And as part of that, before we entered into the Delphi process, we conducted a scoping review to see what's there in the literature in terms of long-term outcomes in trauma, and we identify all the different constructs and measures, patient-reported outcome measures that were used to measure those constructs, and so that we can present that to the panel of experts. And what we found in pain was very interesting. In fact, we found that there were 125 times where a pain outcome was measured in this articles that we identified. We identified a total of 747 articles. So this really makes us conclude that pain is really at the focus of the research in long-term outcomes in trauma, and that there are certain domains that were assessed, some constructs like pain in general, pain intensity, prescribed narcotic use, pain persistency. But one of the gaps that to me was very interesting was that there are some injury types, some injury classifications that are not being covered in the literature so far. As you can see, most of the literature has been focused on ortho and perhaps in burn patients, but still, there is an opportunity to do more research and learn more about what's going on in terms of pain and long-term outcomes in other injury types, and of course in other specific subgroups. So to conclude, and I'll just want to finish with this slide, which is kind of the conceptual diagram that we have come out after the work we have done in Forte and Entrap, which is really all these domains of health: mental health, physical health, cognitive health, social health. They're all interacting to each other and they affect to each other. It's a huge interdependence between them, and this is what we all end up calling the quality of life, and that determine how these patients do in the long term. All these are associated. So when we need to address them and we need to really come out with strategies to improve care and improve outcomes in this population, we really need to be taking into account all the different domains, and that, for example, chronic pain is just not only treating the pain, or is not only thinking ways in how we can, figure out ways in how to reduce the prescription of opiates, but also how we can start addressing all these other factors that come into play. And then for certain, I think we'll have more effective interventions and more effective outcomes for the trauma patients. So with that, I would like to thank you for the opportunity, and happy to take any questions.
Thank you so much, Dr. Escobar, for that wonderful presentation. And we already, yes, have questions coming in, and guys, feel free to send us any more in the Q&A box or in the chat as we ask him for these questions. Okay, so right now we have someone named Annie. She's asking for your work. How is trauma exactly defined? And does it include collective trauma? And is it limited to physical trauma? Like, for instance, would it include trauma such as interpersonal violence?
Absolutely. Yeah, that's a great question. So for our work and the Forte project, it's limited to physical trauma, and it's only limited to a certain degree of that, of the severity of that injury. So we only include moderate to severe injuries in the project. And the reason why we only focus in this population is because of logistical issues. The trauma population is very large, and it will be very difficult to follow with all the patients. So we're focusing on specific groups to begin with, but that doesn't take the fact that traumatic injury, regardless of the severity, sometimes we see that patients can have very, very poor outcomes in the long term. In fact, in some of the studies we have conducted, we have seen that the risk for developing PTSD is not that much associated with the severity of the injury, but rather to the intentionality of the injury. For example, a person may have a very mild trauma after, a gunshot wound. Let's say it was a gunshot wound to the leg that, didn't affect, like there was only soft tissue that got affected. That might have a very low injury severity score, but the probability of that person developing PTSD might be 5-6 times higher than a person that perhaps can have a higher injury severity score, but that was as a result of a fall, for example. So it really depends on some other factors as well. So and that being said, we want to, ideally, we want to focus in all traumas or accidents, not only in physical trauma, but this is the part where we are beginning with.
Thank you. Okay, and then we had a few questions for you, Dr. Escobar, just in general, about you yourself and how you became interested in the trauma work that you're doing, and then kind of maybe giving us a little bit of a history of how Forte came to be at the Center for Surgery and Public Health.
Yeah, absolutely. So I became interested in traumatic injuries when I was back in med school. So I'm originally from Colombia, and I grew up in a city with a very high rates of violence, and when I was doing some of my rotations, it was very striking to me to see, the amount of patients that were coming up to the ED every day with traumatic injuries, and how that population was pretty diverse. It was, all over, from very young adults and adolescents to, elderly people. So to me, it was really striking to see how massive was trauma, that it can affect everyone, regardless of gender, sex, and race, socioeconomic status, everything. And that to me was very shocking, and also, and in long-term outcomes, I really got interested in the fact that, to me, it was very, very interesting how, we were providing very good care to these patients, and some of them were actually having remarkable outcomes in terms of survival, and patients that came out to the ED very sick, and they end up surviving after the injury. And we were saying, like, wow, this is fascinating how care can really, save lives. And that was very appealing to me. But at the same time, then later, a few weeks in the follow-up visits, then I was questioning, like, whoa, this patient is not able to, go out of work, is not able to walk again, is not able to return to their normal activities. So that really made me question about what was the, how were we measuring quality, and how were we measuring outcomes? Because for the system, that was a successful outcome for the system, and how we measure quality right now in the United States, which is based on survival and short-term outcomes. Those were perfect outcomes. That was a success for the system, and I think that was missing a big part of the story. Is it really, a success if we just save the person's life? But I think the responsibility of trauma systems go beyond that. And I like to see, traumatic injury as a chronic disease rather than an acute event, which really is a continuum of care. And for some time, we have been thinking about trauma as it's okay. It's the bone that is fractured, and we heal it, and then that's it. And then the patient, we're done with the care. And I think it should stop there. It needs to go beyond. It's a continuum from the point of injury up to, when the patient is completely rehabilitated. And that may take months, years, even decades. And that's why I think that was a big question that really, really interested me, and say, and wanted to do some work on it.
Great. Thank you for that answer. Appreciate that. And we got time for one more answer for you, Doctor. It's from Cara. She's asking, do you have plans to use the data from Forte to develop opiate prescribing guidelines similar to those for general surgery procedures developed by Michigan Open and Johns Hopkins? And how difficult do you think it would be to do that given the trauma patients are generally clinically complex?
Sure, and absolutely. Well, I'm not sure what are we gonna find because we're just starting to merge this data that we just extracted from the from the charts about the opioid prescription patterns we really didn't have in the past few years. So we're hoping that we can shed some light on on some issues that are going on in the opioids prescription patterns, and that we can make some recommendations for for the development of guidelines. And that's certainly one of the goals that we that we want to do with the research that we're going to be doing in opioids is provide insightful on data to and recommendations for that. And yeah, and I totally agree. Like the trauma population is it's a very challenging population in many different ways, and usually coming up with with guidelines for this population is challenging, and due to the fact that it's a very diverse population, because we're talking about the elderly and young adults at the same time, which are completely different populations that may have completely different risk factors and conditions, the type of the injury, and so it's really diverse, which I think it's what makes the field very fascinating. But at the same time, that comes with big challenges, and we need to figure out the ways in how on how to make things selected to certain populations when the case is indicated, and whenever we need to do it at a broader scale, then do that.
Gloria, you're on mute.
Thank you. So we're so happy that you joined us today, Dr. Escobar. We wanted to give folks an opportunity to follow you on Twitter. As you can see, it's at 1PH19. Also, if you have any more questions about, again, our panelists today, feel free to email me at gbrand@bwh.harvard.edu. Again, in lieu of time, we're going to try and move on, and we're going to go to our next presentation, which we're going to have our students from Harvard. They're both fourth-year graduate student or undergrad student medical students, and their presentation today is called Resilient Narratives of Hope from Boston's Opioid Crisis. We had the pleasure of hosting them last year for Recovery Month, and they're kind of bringing this online for us today so that you'll be able to see more of a unique perspective. And we also wanted to give you guys just a little bit of input as to what the phase 2, the opioid crisis, looks like. We did want to have a recovery coach here to talk with us today, but I think this is kind of an insightful next best thing. So welcome Mimi Yin Lee and Joyce Zhou, again, both fourth-year Harvard med students. Thank you guys for joining us.
Well, thank you so much, Gloria, for inviting us. And we're really excited to be here with this panel of other people who are doing such awesome work in this field. And I think I want to share a component of what we did in this project with you guys, but I think it's highlighting work such as the ones that are talked about today, as well as stories from people who are out in the community doing important work in opioid recovery. And so, yeah, as Gloria said, our project is called Resilient Narratives of Hope from Boston's Opioid Crisis. And what this project is a photo narrative exhibit that's actually up at the Brigham. It's next to the M elevators in the second floor. So kind of behind the Gen Center and the Endoscopy Center, if you've ever walked by there in that hallway. But our project, the whole point was to share these stories of recovery, share stories of change, and really show the face of people who are in recovery as well as their words. And so if you go on to the next slide, Mimi, I'll briefly talk about what inspired this project, and Mimi will walk you through the kind of the meat of this presentation, which is actually sharing some of the quotes and some of the images from our project. So briefly as background, what inspired us to do this project? And so both of us were first-year medical students when we had been learning about the opioid crisis, both kind of from the medical perspective, but also from popular media and from being engaged in the world and hearing about the opioid crisis affecting the country. And something that struck us was that we were surprised and kind of, I think we were disappointed to see that many of the images that were featured in these articles tended to be fairly dehumanizing. Pictures of people who were unconscious, pictures of people who were actively shooting up in the streets. And we found that this was something that kind of portrayed the opioid crisis in this like stigmatizing, dehumanizing way. And I think the ways that they talked about the opioid crisis was about death, about tragedy, about how this was ruining, how the morals of America were being affected by this crisis that was going on across the nation. And we were wondering whether there was more to this conversation. And so particularly we were interested in the question of, well, are there stories of hope that we can use to inspire other people to that opioid recovery is possible? And are there people doing important work that is leading to change? And so what this led to was this journey that we took across, I want to say, the course of maybe a year and a half from our first year to our second year, where we worked with a number of other medical students as well as early healthcare professionals in gathering stories and gathering images of people both in recovery and people doing important work around opioid use recovery. And so we collected about 40 to 50 portraits and interviews with these people, and we really thought about how their stories complemented each other and really what some of these overarching themes were, which Mimi will share. And so across the course of this project, we came up with these 4 big themes and had people speak for themselves. And so we highlighted quotes that they shared with us, as well as some images that we thought featured their humanity and really showed a different side of the opioid crisis. And so I will let Mimi talk about some of these themes and share some of these stories with you.
Thank you so much, Joy. So from all the stories that resilient participants shared with us, 4 themes really stood out. Those were empathy, healing, change, and belonging. And I just want to take a few moments to share with everyone some of the portraits and quotes that exemplified each of these themes for us. So for the theme of empathy, many of the people that we spoke to highlighted the need for us to really look beyond the statistics and understand the stories of each person as an individual. This is Roberto David. He is a father and a person in recovery. He says, "In order to understand addiction, I used to always say, if you've never been there, you never know. You can't really sympathize, but that doesn't mean you can't try. If only people would research more, try to get to know people more, get a little more hands-on, and get a little more face-to-face." Our second theme is healing. So many of the stories that we heard from people touched on the support networks and the treatments that have really helped them along their path of recovery. This here is a picture of Ephraim and Lori. Ephraim is a recovery coach and a person in recovery, and Lori is a nurse. They both work as a team at MGH Charleston to support patients in recovery. And Ephraim tells us, "Recovery coaches are the bridge. We are a bridge to the nurses, a bridge to the doctors, a bridge to the psychiatrists. We are the bridge to a new way of living. And even after 5 o'clock, we're the ones who stay connected with our patients." Lori says, "We're their cheerleaders. We believe in them before they believe in themselves. We're the person that gives them a hug when they're down in the dumps. To help them along the journey and make it a little more bearable, that's why I do what I do." The dedication that Ephraim and Lori show really reminds us that healing takes a lot more than medicine. The medicine is a big part of it, but only a part. It really does take a whole team of people who truly care for their patients as human beings. Our third theme, which is the theme of change, is really meant to highlight the work that different agencies and organizations in our community have done within their own areas of expertise to tackle the crisis. Dr. Monica Burrell, the commissioner of the Massachusetts Department of Public Health, has been spearheading efforts to make data-driven policy recommendations to support individuals that sit at the intersection of multiple identities. And she says, people aren't categorized by buckets. A person may be staying in a homeless shelter with a mental illness, with an opioid use disorder, and also have a child in foster care. This is the constellation of the person we are trying to help, and unless you understand how all the pieces fit together, you can't help them. Last but not least is our theme of belonging, and for us, this final theme was really the undercurrent for our entire project, the reality that we are all one community, and we really wanted to highlight the importance of recognizing and honoring how we are all connected to one another. In the words of Sarah Mackin, who is a harm reductionist and a program manager for A Hope Needle Exchange, she says, sometimes you just have to throw love on people. Give them a clean pair of socks, give them a cup of coffee, and just love them no matter the shape that they're in. On the days that I feel the most helpless, most frustrated by the system, or really ineffectual, I just try to love people really hard. Sometimes the most powerful thing you can do is show kindness, love, and compassion to someone who is suffering. They need to be reminded that there are people who love and accept them without judgment. I also wanted to share the sentiments of Lauren Sabbath. She is the Assistant Clinical Director of Hope House, which is a residential treatment program. She says, you can't scare somebody into being sober. Give somebody hope that they can live a different life and that they deserve something different. Tell them stories of recovery. That is more powerful than saying, you know you're going to overdose again. You know your family is going to leave. This is the last straw. Lauren's words really perfectly capture exactly why we think stories of hope are such a necessary part of the narrative of the opioid crisis. And that's not to say that the opioid crisis isn't devastating. It is truly a tragedy, and yet there is also hope, and that is also a really important chapter that we need to recognize, because without hope, we lose a lot of patients who may otherwise have come to care, and we lose a lot of clinicians who may otherwise be willing to work with patients with opioid use disorder. So I'm just going to turn it over to Joyce to share a little bit about what's kind of come after we launched this project in 2018.
Yeah. Thanks, Mimi, for walking us through some of these images and stories. And again, if you want to see the exhibit in full, it's still up by the M elevators on the second floor of the Brigham. And so just to wrap up about kind of what came next, what happened after this exhibit was released in September of 2018, I think we reflected on what were the core tenets of what we were trying to do. I think we thought about this idea of using art and narrative to empower people to share their stories. We thought of art and narrative as an important way to educate ourselves, as well as educating the communities, the public, and then also engaging the public and having conversations about what these people's stories and experiences really mean and can show us about hope and empathy. And so sticking with those core values, I think what came next included students such as Ariana Kam here, who took one of the stories of an interviewee, Pesha, who then who created this animation of her story, and to be able to visually animate kind of the experiences and feelings that this person was going through. But then other students that followed, so New Leadership and Resilient, started to do other projects related to art and narrative medicine. And so, for instance, they started making art with some people visiting the Bridge Clinic as a way to help them tell their stories in a visual way. And then there has been kind of continued talks about doing other things to share these stories in other mediums, such as through podcasts and other ways to amplify the stories of change, the stories of hope, the stories of community building. And so we're really excited for what other students are doing, and this is a continued effort to bring narrative medicine and art to the opioid space. So I think that's the end. If you guys have any questions, we're happy to talk about them.
Thank you both for such a comprehensive and compact presentation that really gives us quite a bit of information on why you came to the table with this and what inspired you to do this work. And in lieu of time, we wanted to just remind people that this project is available by the elevators, as she spoke to. And if you have any more information about our panelists today, feel free to, or questions for our panelists today, please email gbran@bwh.harvard.edu, which is included in the information that you received for the program today. And we're going to try to bring up our next panelist. I don't think we have any pending questions for you right now, Mimi and Joyce. But again, if we do, people just wanted to know where it was and how they could access it, and you already spoke to that. And so that's great. And again, we'll kind of give them more specific directions if there's any issues. And again, this will be recorded, so you'll be able to see their email at the end of their presentation as well. Okay? All right. So we're going to move right on into our next and final presentation, which is from Dr. Gershonik. Dr. Gershonik is a medicine hospitalist and clinical informaticist at the Brigham. He also works as a pediatric hospitalist at Children's Hospital in New Orleans. We're going to give him a minute to bring up his presentation. And I don't hear you, Dr. Esther.
Can you hear me? Can you hear me now?
There you are.
Okay, sorry about that. My apologies on my delay.
So welcome again, Dr. Gershonik. I was going to give you an opportunity to just do a brief presentation or introduction of yourself, and then you can jump right into your presentation.
Yeah, thank you so much, Gloria. And my apologies on my delay here. I'm currently serving as a hospitalist at Brigham Women's Hospital and on service. And sometimes patients, you know, have certain emergencies, and I just happen to have one with my team. But I am a medicine and pediatric hospitalist here at Brigham Women's Hospital, and have a background in public health, informatics, and health equity. And so some of the work that I was looking at sort of builds upon my background of being a clinician, a human first, a clinician second, someone with a background in public health who's done work in the public health sector, and then also someone who is just trying to put some of these pieces together to line them up in order to better understand how this impacts our community. So with that, I was going to share my slides here. I was going to take this as a perspective from looking at both clinical, public health, and data, which is my background, as to one of the approaches that I'm looking at currently around the impact of COVID-19 on the opioid epidemic. Am I allowed to share my my slides here?
You should be able to. Can you get an share screen?
All right.
There you go.
Okay. So originally, thank you so much, and sorry for the delay there. Originally, I was going to talk about the impact of COVID-19 on the outcomes of people with substance use disorder, but instead I want to talk about what the impact of COVID-19 is on an opioid syndemic. I have my email there in case anyone has questions or want to email me. Now, for those of you who don't know what syndemic means, it's the interaction of two or more coexisting diseases and the resultant excess burden of disease. Often it correlates with sort of the structural underlying conditions of health inequities, which I know has been talked about. And with the opioid syndemic originally was the idea of, with the change of opioid prescriptions to IV drug use, how that then led to an increase of both hepatitis C in some regions across the country, and how the opioid epidemic sort of led to that increase due to its transition to harder medications and the use of IV drugs. It's interesting, 2-3 years ago, on the news everywhere, there's the idea of how the opioid epidemic had become the last public health declaration emergency. And there's discussions of how Hep C was increasing as well, and how we could combine those two in the setting of having to address both of them, whereas traditionally public health was addressed in silos. Opioid epidemic is one thing, Hep C is separate, HIV is separate. But in reality, what we're seeing is more and more of how these interplays of different public health issues come into account. And this is just some highlights of what we see, both from what we see in the media around the opioid epidemic and how it's intensified with coronavirus, COVID-19, and then also what we're seeing in the academic journals in reference to how we have sort of with this pandemic, how it's making this other epidemic worse. Now, what I'm hoping to do with this brief presentation is just to do an overview of how COVID-19 may impact substance use disorder populations, what the data is around both and the differences between both, and critically approaching this new landscape that we find ourselves in. Now, as many of you know, and as I probably do not have to repeat too much, COVID-19 has put stresses on our society, especially the substance use disorder populations. There's been a promotion of social distancing, though I like saying physical distancing because I feel like we need social support. There's been hardships on employment, homelessness, social determinants of health, and exacerbating current issues. But also specifically for those with opioid use disorder, you see a decrease in the access to syringe exchange programs, a decrease in access to Narcan, to treatment, and to support groups. And this is a nice little chart that I had seen, a diagram that has expanded how this could potentially, how COVID-19 could be further impacting opioid use disorder and other substances. And now all these stressors can increase the idea of where a craving may be needed, where there could be a relapse, where there could be withdrawals, dependence, tolerance, so forth and so on. And so I just wanted to share that just to sort of add that human part of what we're all going through and the stressors of COVID-19 can impact us. And this is something that we've seen in other disasters as well. I worked during Hurricane Katrina and also have friends who worked during Hurricane Sandy in New York. And one study, and studies have come from both of those situations, along with what's come from the automotive industry when when many people lost their jobs, is that there was an increase that was seen in many patients who inject drugs, increased experiences in withdrawal, not having the clean needles that they could use with the syringe programs, and that often they're not continuing the opioid maintenance therapy that they were on, and it's led to sort of worsening of the other diseases that we see with such endemics, such as HIV, Hep C, and other disease processes. And so pretty much highlighting, how COVID-19 and all the stressors of it can impact all of us, but primarily how it can impact the substance use disorder community. The other objective I was trying to get just from this brief talk in this limited time is talking about, what I saw this morning when I went on to the New York Times. It's amazing with COVID-19 how every day you can see what's going on both across the country and in each individual state and cities. This literally is yesterday. We can see across the nation what is going on with COVID-19. And if we take a closer look at Massachusetts, we can take a closer look as to what was going on yesterday. Even if we go to the CDC website, they have everything from yesterday that was going on. And if we go to the Massachusetts Public Health website, we can see what's going on today or yesterday with COVID-19. However, if we take a look on the CDC's website and take a look at what's going on with drug overdoses and opioid use disorder, this is from today as well. You can only get information from 2 years ago. And at the bottom, I sort of show what the information is on the data for Massachusetts. Furthermore, when you break it down into heroin, and synthetic opioids, you can also see that this information is from 2 to 3 years ago. So the question we often have to ask is, if we don't have data in real time, how can we address it, especially compared to COVID-19, where we have such data in real time to where we can minimize the spread? If our goal is to do this also with opioid use disorder from a public health standpoint, then we have to be proactive in getting some of the data and using such policies. Furthermore, with both COVID-19 and with opioid use disorder, we found that there's a lot of undercounting of many cases or probable cases. These articles sort of show how often in a setting of opioid use disorder and opioid overdoses, it's difficult to properly count because often certificates aren't filled out properly. It's difficult to surmise the reason for it. And slowly with COVID-19, we're trying to understand, because of the limited testing and where we are with testing, this is also leading with some of the aspects of what we know thoroughly about this pandemic. Furthermore, with prescribing rates that we know about opioids, we can only get up to date from 2 years ago compared to the now prescription drug monitoring program that each state has that can advance that information in more real time. Furthermore, the New York Times, when they published information on the opioid use disorder, they used this graph, and this again was done a year after or 2 years delayed from when the information came in. So what we have with the issues here is that both with COVID-19 pandemic and the opioid epidemic, with COVID-19, we see immediate reporting, both from the New York Times or from the CDC or from our state public health entities. Whereas with the opioid epidemic, we often see delays of a couple years. So if we're going to address these two together, we need to have some of that reporting at the same time. But what we do find with both of them is issues with testing. I know when I first saw a case here in early March, I couldn't get a test on a patient that I thought potentially had COVID-19. And with the opioid epidemic early on, there wasn't the ability to test for heroin, fentanyl, and other more specific opioids. There's also issues with reporting of testing. In smaller towns and in rural areas, they often don't have the capacity to do these things. And often there's some misdiagnosis or difficulty diagnosing the byproducts. If you have a respiratory issue with COVID-19 or a respiratory issue with something else because you don't have the test, it's hard to surmise that. And what we're seeing is also how both of these pandemics, epidemics are making vulnerable access for folks in rural America, those who are incarcerated, and those with social determinants of health aspects. But for treatment, there's been an evolving process. SAMHSA and also the Drug Enforcement Administration have now allowed the expansion of some of the treatment which previously only allowed folks to go to their methadone clinics or only could get a certain amount of medication for their substance use disorder. And we've also expanded on the process of being able to do telehealth for some of these visits that previously were in person. And so often what this is doing now is minimizing some of the stigma that comes with the disease, and also allowing folks, instead of having to go every day, having sometimes up to 28 days of their medication so they can take care of it themselves, and allowing some of the evaluations to be via virtual health. While all this advent of telemedicine has helped access folks who haven't been able to come to the hospital, it's expanding the use of digital health for hospital systems. However, that also comes with the caveat that many populations to some of these digital aspects of telemedicine that are being used for substance use disorder. So what I want to show briefly is, here is an advent of how things have progressed during COVID-19 with how visits are being done. This is in Kaiser Permanente with aspects of face-to-face encounters, as you see here for the emergency room, urgent care, and primary care, and how the advent of email, e-visits, video, and phone has been advancing as well in this new virtual world that we're living in. This is thanks to Dan Cavanaugh and Terrence Sampson and the virtual care team at Brigham. You can also see here how through the advent of COVID-19, how their virtual visits have increased in volume, and as how things have opened up, how that volume suddenly increased and then decreased as people are able to get back into clinics as well. Lastly, I have to credit Joji Suzuki and Lisa Irwin for this data that I tried to line up. This shows the in-person visits in the early aspect for substance use disorder at the Bridge Clinic as COVID-19 was starting, and then how they did a great job of transitioning to virtual care, and how down the road, how some of this is going between a mix of the two in order to ensure the access to the care that some of these people need. So with that, I just wanted to provide a brief overview of both opioid overdose rates and COVID-19, how these epidemics have worked together, how they both are the last two national emergency disasters that have been declared by the nation, and how they both could be intertwined. Furthermore, I wanted to highlight those gaps that there are in the data, how with opioid use disorder, because it's not a mandated, because there's not a policy to mandate the reporting of it in real time, that's delayed, whereas it's not with COVID-19. And that with the access to care via virtual health, we also have to take an understanding whether people who this is affecting disproportionately have the access or have the ability to have such virtual care visits in this time of need. So with that, thank you, and I appreciate the time.
Thank you so much, Dr. Gershonik. It looks like we still have a good 56 people that are hanging out with us, which is awesome. That was a really comprehensive, succinct, and thorough presentation, and we really appreciate it, and we appreciate your time. I did want to ask you a few questions and allow for people to ask questions if they're still willing to. Those that are still on, if they had any questions, I'll give the floor for them first. And if indeed no questions come through right away, we'll ask you a couple more questions about you, how you got into this work, and then we'll conclude. Great. So Dr. Gershonik, can you just give me a little bit more information, or give the group a little bit more information about what you feel are some of the most prominent disparities that you've recognized in opiate use disorder, both prior to the COVID epidemic as well as during?
Yeah, thank you for that question, Gloria. You know, there's a couple of different things that I think I try to do when I look at such issues. One is organizing the data in a way to where you can understand the broad aspects of some of these disparities. So understanding where structurally in the community we're not being able to access such items. You know, I sort of broke down, I know we had discussions earlier on social determinants of health, racial, ethnic equity, and inequities and disparities, along with incarcerated and rural populations. And I think each of these scenarios sort of have a unique aspect to access that we need to sort of figure out how to connect better. Furthermore, there's been strong lines around previous broadband issues and connections in this item of the pandemic, that people who think virtual care is so easy, it's often for those with resources, whereas other folks who may not have Wi-Fi, cell phones, computers, or who have to work and are essential personnel often don't have the same ease to take off of work. And so I think both pre and post pandemic, you have to take a look at that broad perspective of each of those unique populations to address how you can properly take care of that patient.
Thank you. And then we have another question coming through from Sarah. She's asking if you could speak in any way to the statistics of Brigham Health workforce members in this space.
If she could, Sarah, if you could elaborate on what you mean by the statistics of Brigham Health workforce members, that'd be great.
Sarah, do you mind elaborating for us, please? And while she's doing that, I'm going to go ahead and move into another question I have for you. So, Dr. Gershonik, what would you like to see both in research and treatment as it pertains to OUD within the Brigham and within hospital systems at large?
Yeah, so one of the things, I'm currently serving on the COVID-19 Brigham Health Diversity, Equity, Inclusion and Response team. And I think some of the issues that I mentioned, both to, access to care, is something that we have to further evaluate. and understanding where there may be some of those barriers. I think Joji and the group at the Bridge Clinic has done a great job of their connections with their patient population. But I think what we learned through COVID-19 is instead of the traditional hospital-based care, we have to figure out how we can reach out better and connect better to the community and ease the ability for us to understand their issues better to better serve them.
Okay. That's great. Okay, Sarah is being more thorough with her question, and she's saying what she meant is the workforce in terms of workforce members, employees, faculty, students that work at Brigham Health. So Sarah, I'm going to go ahead on a limb and ask, are you referring to how many people within the workforce that deal with opiate use disorder? Is that the question that you're asking, or how else would you like to elaborate on that question, or am I getting it correctly?
And as Sarah responds to that, the only other thing I want to add is that if anything, what we learned with the opioid epidemic and with COVID-19 is there needs to be a better interplay between public health and healthcare delivery in order to properly connect and have a broader perspective and holistic perspective on our patients and the population. Okay.
Okay, got it. Okay, so perfect. So I think I was on the right path. So she's saying she's trying to determine the numbers of substance use disorder and within the Brigham in terms of the workforce population, and whether or not we saw an increase during the pandemic. Thank you, Sarah.
I'm still a little confused by the question, because I think the question then is how many people with substance use disorder have been hospitalized during this time of the pandemic, or is it a question of how many employees, faculty, and students are taking part? Because it's two different things. One, we don't know the extent of the faculty because that's confidential information. Two, we have seen both across the United States and at Brigham more and more people having the ability to treat substance use disorder by getting their X factors so they can prescribe Suboxone. And three, I think, overall, I don't know the numbers on how many folks with substance use disorder were hospitalized during COVID-19. But one of the things I am looking at is to sort of see if there's a correlation between the morbidity and mortality of those folks who died of COVID-19, and to see if any of them had the comorbidity or predisposition to substance use disorder. Because one of the things that's presumed currently is that with less people out in the field and the concern of droplets early on, that there is a concern of EMS going out, giving of Narcan, and the access to some of the things that were primarily preventive measures for opioid use disorder and substance use disorder. So I don't know if I'm answering all those questions. I don't know the exact numbers, but one of the things I will be evaluating is to see how many of those people who came in with COVID-19, both who died and who were just hospitalized at Brigham, had substance use disorder, and if they were properly treated.
Thank you, Dr. Gershonek. I think that's a wonderful answer. And I think that she was probably being more specific about even some of the workforce and how the workforce within itself has been dealing with opioid use disorder. But again, those are like probably more questions that would be a little bit more integrated within our workforce itself, if that makes sense, and something that we wouldn't maybe have access to beyond our patient population. So, but I'll connect you guys as per usual, and definitely that way you guys can talk offline if need be. Does that sound okay?
Yeah, that sounds great. And I would say, I do not know the amount of employees who have substance use disorders. The one thing that we do know is that these times have become big stressors on everyone. And so there's a lot of outreach to try to support everyone during these times, both within the institution and outside of it. Like I said, I don't like the term social distancing. I like physical distancing while socially support each other during these difficult times.
Sounds great. Well, it looks like we are getting to the end of our symposium. In fact, we've went a little over, but we still have folks here who are still around. So we want to use this opportunity to just promote Recovery Month once again. Thank you, everyone, for taking the time out of your busy schedules. Thank you, Dr. Esteban, for joining us. You're literally like on the grind and going probably right back to the grind. So we appreciate you taking the time. We appreciate all of our panelists today for joining us. Dr. Lena Matau, Carla Matero, Dr. Escobar, Mimi Yin, and Joyce, and Dr. Weiner, who's somewhere not showing his face. And we just really appreciate you guys for taking the time and showing not only what the Brigham is doing around this work, but also how important it is for us to collaborate. And with that being said, just wanted to put a plug out there for the Brigham program in opioid and pain and innovation. We are a fairly new program whose ideals and purpose is to really just end the silos with researchers, scientists, and physicians who and nurse practitioners who work in this space and who are interested in staying connected. We meet on a quarterly basis. We usually have presentations just like this one, at least one, with our quarterly meetings, and then we're working on trying to make it a more comprehensive program so that it could be more of a resource to physicians, scientists, and researchers and innovators who work in this space. So if you want any more information about POPI, how you can get involved and attend more events like this, please email me at gbrand.bwh.harvard.edu. I've also put in the poppy.bwh.harvard.edu website somewhere within the Zoom chat. This program is being recorded, so you'll be able to get this information through an email blast. You can also go to bcore.bwh.harvard.edu, which will be posted there. It may be posted on the BRI website as well, but we'll get all that information out to you so that you'll be able to go over these wonderful presentations in detail at your leisure. So thank you guys again for your time, and please enjoy the rest of your day, and please send some love to folks in recovery and those that are working with those in recovery. And if you got purple, put it on today. This is a good day to wear some purple. All right, thank you guys. Take care.